Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Today's podcast will focus on endometrial cancer with Drs. David Miller, MD, from the University of Texas Southwestern Medical Center. Dr. Miller, if you could introduce yourself, please.
Sure. I'm David Miller. I'm a gynecologic oncologist here in Dallas at the University of Texas Southwestern Medical Center. I've had the great privilege of previously being the director of the division. I've been long active in clinical trials, particularly as it relates to endometrial cancer, actively participating in the GOG and the NRG, where I'm currently the deputy director of membership and quality for NRG oncology.
Okay, thank you very much. And our other expert today is Dr. Alexander Olawaye, MD, from the University of Pittsburgh Medical Center. Dr. Olawaye, if you could introduce yourself, please.
Yes, thank you. My name is Alex Olawaye. I'm a gynecologic oncologist at the University of Pittsburgh School of Medicine. I do practice. Significant portion of my work is clinical work, but I also am the head of gynecologic cancer research for the University of Pittsburgh, and I have had the privilege of serving on the board of directors of the Gynecologic Oncology Group Foundation, and participate also in NRG trials, and I've been part of NRG for several years. So it's nice to be part of this podcast.
And with Dr. Pamela Solomon, MD, from the University of Texas MD Anderson Cancer Center. Dr. Solomon, if you could take a minute and introduce yourself and give us a background.
Sure. I'm very happy to be here. Like Rick said, I'm Pam Solomon. I'm a professor in GYN oncology at MD Anderson Cancer Center in Houston, Texas, and have the pleasure of taking care of women with gynecologic cancers, and have a special interest in both research and clinical care for patients with endometrial cancer.
Okay, thank you very much. So our topic today is the use of biomarkers in the management of endometrial cancer. So I guess, what role do biomarkers currently play in the management of endometrial cancer, and what role might they play in the future, I guess, as newer biomarkers become available? And so Dr. Olawaye, I think I'll start with you first, if that's okay?
Yes. So biomarker usage in the treatment of cancer actually speaks to precision medicine, because when biomarker informs treatment, what that means is that the particular treatment that you're looking at may not be applicable to a large group of people with the index cancer that you're considering, but in the group that it applies to, the efficacy is expected to be very high. And when we do that, it does two things. One, patient is having maximum benefit. Two, we're not subjecting people that are not going to benefit to the toxicity of that therapeutic intervention. So biomarker, in my opinion, is very important. An example, for instance, just as a start, is to look at just simple endometrial cancer characterization into the deficient mismatch repair group or proficient mismatch repair group. And we, in the last 5-6 years, have had the pleasure of or honor of having immuno-oncology introduced to endometrial cancer treatment, especially for advanced and recurrent disease. And the gain in benefit for the group that is deficient mismatch repair status, their tumor, that group has massive benefit from this group of agents. And so that's just an example of matching biomarker status with a targeted treatment. And the drug does work in the proficient mismatch repair group but their benefit does not come close to what we get in deficient mismatch repair group. So that's just a good example, but there are many others.
All right, just as Dr. Alawi mentioned, we have what we're going to see is an increasing role of various biomarkers to help us identify the most active therapies that we might offer our patients. We have a number of biomarkers that, over the years that we have identified that are capable of giving us prognostic information. But I think the thing that is particularly advancing recently, as Dr. Alawi mentioned, with identifying biomarkers such as microsatellite instability, mismatch repair, that will predict response to immune therapies. We now are seeing evidence of other biomarkers such as HER2 that might predict susceptibility or responsiveness to HER2-directed therapies. So I think it's going to become, we can anticipate that it's going to become more and more important in the treatment of the various types of endometrial cancers. We previously frequently focused on histology, such as whether a patient might have had a serous tumor, but now we have various molecular markers that are probably going to help us tailor therapy to patients even more.
I think that the role of biomarkers continues to evolve in women with endometrial cancer, and I think a lot of research is ongoing to best understand how we use biomarker testing in treatment. In our current state, for patients with a newly diagnosed endometrial cancer, we standard of care test the tumor for estrogen and progesterone receptor positivity, for P53 status, as well as tests for mismatch repair deficiency through immunohistochemistry. We're incorporating more next generation sequencing into our upfront treatment, and specifically POL-E testing, as we think these are the current biomarkers that impact the decisions to give treatment. For certain subtypes like uterine serous cancers or carcinosarcomas, we also do HER2 testing up front, and we're seeing this kind of more and more in other tumor types as well.
Okay, so is it usual for patients, do they want to get the after they've had a diagnosis, do you ever get the full panel of biomarkers, the tests where you can get, it's either liquid biopsy or biopsy? Do you ever have patients that request that, or is that a routine thing done in practice?
Yeah, I think that it's still kind of a little bit in the research setting. In our clinical practice, we actually have a research protocol looking at or collecting next generation sequencing on baseline tumor for patients with high-risk subtypes. And we also have a prospective clinical trial looking at liquid biopsy preoperatively, postoperatively, post-adjuvant therapy, and then every 6 months for follow-up. So I think the testing is commercially available. I think it's usually paid for, but not consistently paid for by insurance. So we're trying to look at it from a kind of programmatic standpoint or research standpoint so we can better understand how to use the biomarker testing in treatment decisions.
Okay, thank you. So you mentioned the HER2. I know that's a sort of a big topic in the breast cancer field at the moment, and the antibody drug conjugates for the HER2 too low patients, and I know that there's some other targets too with these kind of drugs. Is this something that's coming into play in the endometrial cancer field, Dr. Olayiwoye?
Yes, indeed. For actually, Dr. Amanda Nichols-Feder from Johns Hopkins has done 2 studies now. One of them is small phase 2 study, and the other one, a much larger study that I believe is either just concluded or about to conclude, looking at the impact of targeting HER2 in serous endometrial cancer. And the initial study showed very significant benefit in patients that have high level HER2 expression, 3+, or if they are middle of the road expression, and the in situ hybridization shows that there is real HER2 expression. We give them trastuzumab, and this group, when you combine trastuzumab with chemotherapy and proceed to give them trastuzumab maintenance therapy, they gain both progression-free survival and overall survival benefit. And therefore, a lot of us now, when we are treating serous endometrial cancer, especially advanced and recurrent group, we would test for HER2 new expression. Now, there is a twist to that story, because the targeting of HER2 expressing tumor has taken a new dimension with the production, or actually FDA approval of the drug farm trastuzumab deruxtecan, which is like what I call the ultrasonic version of trastuzumab. And I can only imagine that if we substitute that for trastuzumab in HER2 new expressing serous endometrial cancer, we're even going to gain more benefit for those women. So yes, it's an area of focus of GYN oncologists at this current time.
Well, I think this is just going to be one of many that are probably going to be further identified as our NGS testing becomes more sophisticated. We get a better idea of what things to look for. And as we get agents that are developed that can target these things.
Mm-hmm. Sort of routinely, what are the markers that you would use day to day in your practices? Routinely. So, Dr. Oluwaye?
So let's just talk about endometrial cancer in general. So when Professor Miller and I take somebody to the operating room, and the result of the surgery comes back, i.e. the pathology report, in most institutions now, we don't actually have to ask the pathologist right off the back. They already do immunohistochemistry as an indirect screening for Lynch syndrome, looking for the Lynch-associated proteins, which is MSH, 2, MSH6, MLH1, and PMS2. And there is also a gene called EpCAM. And those genes are, the immunohistochemistry signature of those genes are those proteins. So if the patient, the tumor does not express one or two of those proteins, that would be escalated further. If it's MLH1 or PMS2, then we do what we call hypermethylation study to know whether this was a somatic event or a germline event. If it's like a germline event, or the tumor does not express MSH2 and MSH6, we'll send them for direct genetic testing to see whether they have Lynch-associated, they have Lynch syndrome, which is impactful for the patient. Now, when it comes to using immunology or immuno-oncology in these patients, if they need such, if they have advanced disease, it doesn't matter whether they have germline, deficient mismatch repair gene status, or it is due to a somatic event like hypermethylation in the tissue. Both groups respond very well to immuno-oncology, so that emphasizes the need to do that. That is one routine test that we do. If the patient has serous endometrial cancer, as you have heard us say, especially advanced and recurrent disease, we want to know whether that tumor is expressing, HER2 new, because that will allow us to use HER2 targeting agents like trastuzumab or the Enhertu drug, which is farm trastuzumab deruxtecan. We also, if I must say quickly, before I turn this over back to you, there is POTEC 3, which a post-hoc analysis of POTEC 3 also showed us something that, in early stage disease, sometimes we struggle about who to give chemotherapy to when the disease has high risk features. They show that those people with p53 abnormal tumors actually are the ones that benefited in that study anyway from chemotherapy. So it could help you not only to target treatment to those who might benefit the most, it could help you to avoid giving toxic treatment, because these treatments are toxic. Avoid them in people that are not going to benefit from them anyway.
Yeah, that's an important point. It's not just identifying new treatments, but it may help us inform our traditional treatments, is radiation therapy. For Dr. Alawi talked about the results from the retrospective look back at the POTEC 3 trial. We recently did one of our GOG 258 trial, where patients were treated with chemotherapy, and the experimental arm was the addition of radiation therapy. And so radiation therapy didn't offer much in the patients who had a p53 abnormality or in patients who had mismatch repair issues, but the biggest advantage was seen in the patients who were p53 wild type for the addition of radiation therapy to chemotherapy. So perhaps that is a group of patients, we've talked about a modest advantage for radiation therapy, but maybe if we could target that to the appropriate group of patients, those patients might benefit. In fact, p53 wild type, you presume that the p53 is working, but we now have a clinical trial that's open for an agent that appears to be most active in this p53 wild type group of patients. So we have one of our GOG trials ongoing to see if this is going to pan out empirically, as it appears to show in preliminary data.
Okay, now that's an excellent discussion on the topic. So does anybody have, either of you have anything else to add on biomarkers in endometrial cancer?
Yeah, I think as far as monitoring, so I think biomarkers can be used in different ways, right? So one is, how do we decide the best treatment for a particular patient? And, we really try to emphasize looking at clinical trials or novel therapies in our practice so we can continue to understand the best treatments for patients. And many of the clinical trials now are biomarker driven. So if we don't have molecular testing or mutational analysis at the time of diagnosis, we definitely get it at the time of recurrence. That can help us triage either within standard of care what treatment to choose, or if patients are willing to do a clinical trial, we'll help identify the trial that may be the best match for them based on their mutation status. Right. I think biomarkers like liquid biopsy so liquid biopsy also can be used potentially for monitoring. I think we know a little bit less about that. The FDA has approved Signatera monitoring for patients on immunotherapy treatment. So we have tried to incorporate that into our standard monitoring on immunotherapy. And we've also looked at monitoring using some of these liquid biopsy platforms in patients on clinical trials. But right now, that's not necessarily part of our standard of care practice in many treatment settings.
Okay, well, thank you very much for your time today.